patient. We now have our next speaker, Dr. SHAIL VASAVADA, who is a very prolific cataract and refractive surgeon. Every time we are presented with a new type of lens, the EDOF or the extended range lenses, we are led to believe that, this is the lens and everyone must have that only. So what we want to learn is that, is it for everyone? Should we just put EDOF lenses for everyone? Dr. SHAIL will speak more about that. Over to you.
Thank you very much, and excellent talk by Dr. Sharma, who has laid the ground very nicely for the different varieties of IOLs and the different patients we can choose for each of them. I think the number one reason why surgeons hesitate to implant multifocal IOLs are that they don't want the headache post-operatively, that the patient may come with complaints of photic phenomenon, complaints of poor quality or waxy fluctuating vision post-operatively, and that's probably the major hesitation that all of us have had. With extended range of vision and the variety of lenses that were there previously, the past experience was mixed, particularly with many of the EDOFs that were existing were still diffractive ring EDOFs like Symphony, and therefore the photic phenomenon problems did not disappear. So you still had to counsel them for glare, halos, so on and so forth. And with introduction of good trifocal IOLs, the patient happiness quotient has gone up so much that there's again now a hesitancy that why we should be going and thinking about an EDOF again when the trifocals are working very well. So I think extended range of vision is something which is here to stay, because with increased life expectancy there is increased period of active life, and everyone who is educated, non-educated, urban, rural is on a smartphone and using screens left, right and center. But not all of the patients are suitable for trifocal IOLs. But believe me, everyone wants to, if possible, at least use their phone or read their WhatsApp without glasses every day when they wake up. So what actually is an extended depth of focus IOL, and this is what the FDA approves, and what it categorizes as an EDOF IOL. So any IOL which gives more than half diopter improved range compared to a monofocal control IOL is considered to be a extended depth of focus IOL. And there are several types of extended depth of focus IOLs, including the small aperture IOLs, which are usually suggested only for unilateral implantation, low at diffractive extended depth of focus IOLs, which have the limitation of photic phenomenon, and now newer generation wavefront shaping and spherical aberration modified EDOF IOLs, which reduce the or eliminate the need of rings, and therefore the dysphotopic phenomenon like can be seen in this slide are far and few in between. So the major advantage of an extended depth of focus IOL is that there are no dysphotopsias that we need to be concerned about post-operatively. The disadvantage is that yes, they are not meant for spectacle independence across all distances. So you will have variably patients requiring glasses, particularly for fine print, ranging from 0.75 to 1.5 diopter from eye to eye. In our practice, and it should be across everyone, is that pre-operative workup remains equally thorough. It has to be as if you want to evaluate each eye, it should be suitable for a trifocal or an EDOF. And still, healthy eyes are still the best candidates for any form of these extended depth of focus IOLs. We'll go through some case scenarios. So this was a 56-year-old male. Ahmedabad it does have a lot of industries which are just 20 to 40 kilometers away from Ahmedabad. So he's a manager in one of these factories. He's a myope since a young age, and he's now struggling or is disturbed with glare while night driving, and because of which he now has to carpool with his colleagues, particularly while coming back, because when he comes back the road is not a proper highway, it's a single lane road, no street lights, so on and so forth. So myope with nuclear cataract, his main activities are supervision of the field force, so he's not actually the technical person performing it. Checks daily logs, he drives back to the city through the country roads, so as to say, and he wishes less dependence on glasses, but he doesn't like to carpool, and he would like to continue driving as long as he possibly can. So since glare and night driving are his primary concerns, therefore trifocal is not suggested in this case, and we decided to go ahead with a bilateral vivity in this case, an extended depth of focus with a target of emetropia in both eyes, as distance vision is of predominant importance. We explained to him that he will need glasses for reading, but the dependence will be less compared to a monofocal IOL. Post-operatively, he did very well for distance, intermediate and near, and in our office with bright light and good contrast, he manages to with strain read N6 also. So he tells us that in his functional life, he's able to drive comfortably now on his own. His reading vision is fairly good. He says he hardly ever needs to use reading glasses. He uses them mainly while actually checking the numbers, checking the bills and accounts. And he uses about 1.5 diopter, 1.25 diopter reading ad for this purpose. The other concern that we had was that when there are these modifications in the central optic of the IOL, does it actually affect the aberration profile that is going through this eye? So this is that same patient to show that the internal aberration of coming from the IOL is negligible, which means that even these modifications that are being done on the surface of the IOL are not causing any changes into the internal aberration profile. Another case of a 64-year-old lady actively does stock market trading and analysis on her desktop. Very well to do, but children are settled abroad, and husband is suffering from chronic ailments, almost bedridden, doesn't drive. So she's the main person running the house. Hypermetropia with presbyopia, she's keen on spectacle independence but doesn't want to compromise on quality of her vision because she knows she has to hold the fort at home. So in the first type, we decided that we might go ahead with an extended depth of focus VVT, and we chose target emetropia, and like in this case 24, and we discussed that we will see how the outcome of one eye is, and if we want to consider a slight myopia in the other eye. This is just to show the changes on the surface of the IOL that are there on the VVT. These are the ones that are responsible for causing the extension of focus. Post-operatively, she's doing very well for distance and good in intermediate and fairly decent near vision. So for the second eye, instead of going for 22, we chose one target more, that is minus 0.5 diopter of myopia for the other eye. Keep telling her that not to compare both eyes, and she did extremely well post-operatively, binocularly for distance as well as near, and she hardly uses glasses post-operatively. The only time she uses them are for reading the expiry dates on her husband's medicine sheets. And there are now articles in literature to show that if you do a slight target myopia in the other eye, you can consider it improves the near range of vision. So the 52-year-old ophthalmologist, active cataract surgeon, unilateral PSC, and he goes to a peripheral center once a month, drives on his own, of course, like most of us, as a visiting surgeon to a nearby town. His otherwise ocular profile is suitable. He's unilateral cataract. He doesn't implant too many of these IOLs in his own practice. He was considering the idea, his colleagues had suggested that you can consider some of these monofocal plus or EDOF IOLs, but he was very sincere as a unilateral cataract. So we had a detailed discussion regarding the pros and cons, and we went ahead with the VVT in his unilateral cataract eye, and he has excellent distance and intermediate vision, and he says that he's able to drive on the highway very comfortably even at night, and he hardly ever uses glasses when he's at home except for reading the newspaper. Doing very well and no problems even while operating cataract surgery. Another 60-year-old ophthalmologist, very active cataract surgeon, we did a toric monofocal for him in 2017, myope, and he's using post-operative progressive glasses. And now he's come for his left eye, and he's himself very keen that, I would wish if I can reduce or improve my intermediate range of vision so that in my routine functional life at home, I'm less dependent on glasses. So once again, we discussed the pros and cons that you have a monofocal in one eye. We can consider, we feel this should work binocularly quite well. Do not compare the vision between two eyes, and you'll still need, particularly for near work, glasses. So we went ahead and did an VVT in the other eye of a toric monofocal on the other eye, and here you can see in the undilated state, it's very well centered and the IOL is well placed in its axis, and post-operatively, he's extremely happy subjectively, and he personally doesn't find any much difference binocularly when he sees with both eyes open as far as the quality of vision goes across his differences. So these two cases to highlight that you can consider EDOFs in a unilateral cataract, or also for the second eye of your own pseudophakic patients in whom you have done a monofocal preoperatively. A 73-year-old gentleman, bilateral cataract, retired but active. On OCT, he had a fine ERM. So these are the eyes, like Dr. Samresh showed, you don't want to consider for trifocal IOLs. And therefore, we explained that because of his retinal condition, he is not a suitable candidate for trifocal IOLs, but you can definitely consider an extended depth of focus IOL, which we did, and his quality of vision is very good, and he requires 1.25 diopter add for fine print. Another 83-year-old, very healthy, no diabetes, no hypertension, and she stays 9 months out of 12 in Canada with one of her sons, and 2-3 months here she comes here to her daughter. She uses iPad a lot in Canada. Nuclear cataracts, and unfortunately she has dry ARMD in both eyes. She would love to be spectacle independent because that's the only thing that she does at home. But she has drusen, so therefore trifocals was out of question. But having some experience in retinal eyes with EDOF IOLs, we did consider and discuss with her that you may need some extra light, your contrast may drop, and you will still need glasses for reading, but your dependence will reduce significantly. So we went ahead with bilateral Vivity, and she's extremely happy. She's N8 for near, and she doesn't use glasses. She says she's very comfortable using the iPad with an increased font size, and this is just to show that her contrast sensitivity with and without glare has also not been compromised and is similar to a monofocal IOL. Last case of a 17-year-old girl presents to us with decreased vision, known case of glomerulonephritis and long term on oral steroids. She's developed now, she's high myope with astigmatism and developed a steroid induced PSC. So we decided that we will consider doing a Vivity toric for her, and because these patients are likely to require YAG post-operatively, with our experience of doing PCCC in pediatric cataracts, we generally do PCCC even for older children, so that the need for YAG and other complications of YAG are eliminated. So here we are performing PCCC after a flax perfectly centered ACCC has been done. And this is just to highlight that even with an open posterior capsule with a PCCC, you can still go ahead and safely place these toric EDOF lenses in the bag, and they will remain centered and they won't rotate overall in the long run. So post-operatively, this girl is doing very well. And she uses glasses mainly for her reading activities, but when she goes to her pre-college, which she is now in, she hardly ever uses glasses. Just to show that even in radial keratotomy cases, if the astigmatism is regular and the topography is regular, using these ASCRS calculators, you can achieve reasonably good outcomes. So therefore, evaluating such eyes is of extreme importance to show the RK cuts. And the contrast sensitivity is also not affected with these EDOF IOLs. Other scenarios where these EDOFs can be considered are low grades of Fuchs dystrophy or early to moderate glaucoma. So I think the EDOF lenses, they do deliver what they promise, excellent quality of vision for even precision oriented individuals, compatible with unilateral cataracts, no dysphotopic phenomenon, surprisingly good near functional vision even with bilateral emetropia, and some mini monovision can be considered in eyes who are willing to accept that. But they are not meant for those who want no glasses. So if somebody says, I don't want glasses for reading, this is not the lens for them, because most of them will require glasses for fine print reading, and it could be as high up to plus 1.5 diopters, and some loss of contrast in dim light. But it seems to be working well even in eyes with relative comorbidities like ERMs, ARMD, post LASIK, post glaucoma, so on and so forth. But I think that will still require more experience. So I think we have a good addition into our armamentarium, which seems to be working well across all ranges and can be considered even for select comorbid eyes. Thank you so much for the patient listening.
Yeah, thanks a lot, Shail. And I think over the last few years of our usage, the two audiences that I really feel this lens works is one in young patients who come for cataract, because a lot of patients in their mid 40s and all don't really read print as much these days. So that near vision cell phones, you can always increase the font by 1 or 2, but because they don't read print and their work involves more distance and intermediate, this in my hand tends to work very nicely. And the second, like Shell brought about, those mild comorbidities, early glaucomas, early query RMs. So there's a lot of clinical judgment involved over there, but that's a segment which was otherwise absolutely, a no-no for multifocal